Hello, and welcome to the Alabama Public Health Training Network. I'm Brandon Vaughn with the Alabama Department of Public Health. Thank you for joining us for our program today, Increasing Breastfeeding Knowledge and Introduction to the Baby-Friendly Provider Program. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I would like to introduce our presenters today, Doctors Jessana Cooper and Elizabeth Sali, obstetrician and pediatrician respectively of the Simon Williamson Clinic, and Dr. Kimmery Bugg, President and CEO of Reaching Our Sisters Everywhere, and Tracy West, Infant Mortality Prevention Coordinator in the ADPH Bureau of Family Health Services. Welcome to you all. I know we have a lot of important information to cover today, so let's go ahead and get started.
Okay, Dr. Bugg, if you don't mind pulling up my screen. Thank you. Hi, I'm Dr. Jessana Cooper, and I'm an OB-GYN practicing at the Simon Williamson Clinic. And I wanted to talk a little bit about baby-friendly and how to become a more supportive OB-GYN provider of breastfeeding and for our patients. Next slide, please. So this is the beginning of my interest in lactation medicine, and this is me and my firstborn child. And hopefully by the end of today, it'll be a little bit like those highlights, what's wrong with this picture. There are a lot of things going on here that I now know will make breastfeeding a lot more difficult, but that is not something I knew when I had my own babies. And it was not something that we were taught in medical school or in OB-GYN training. And I personally really struggled with breastfeeding, and I had a very hard time. This child, William, my first child, we ended up back in the hospital with elevated bilirubin and failure to thrive. And, you know, I didn't know what I was doing. And so I really made it my business to learn to do better so that I would do better with subsequent children, but also so that I would be a better physician and a better support person for my patients. Next slide, please. And what it turns out is I am not alone in this, that actually 2/3 of mothers who intend to exclusively breastfeed their children are not meeting their intended duration. So it's not that families don't want to breastfeed. It's not that this is not the choice that they want for their families and for their children, but somehow we as a system are dropping the ball and these mothers are not meeting their goals. Next slide, please. So I have a background in history and liberal arts, and so I really wanted to understand the problem, to understand why we are where we are and how did we get here. And I find, as in most things, and particularly in our healthcare system, if you follow the money, that sort of explains how we would come from a society that predominantly was raised on mother's milk to one that is predominantly raised on formula. So the large-scale dairy farming played a role. When you have a lot of milk, you need to find uses for that milk. And I like this quote that says, markets are not created by God, nature, or economic forces, but by businessmen. So you create markets for the products that you have. And as it turned out, mother's milk was a product that nobody was making much money off of. And actually with the opposite, as women are returning to the workforce earlier and sooner, particularly in this country, it actually was seen as a cost to have women trying to breastfeed their children. So this then comes into a problem when you see with your patients as far as their decisions about breastfeeding, even if they're interested, and then their ability to continue. The lack of maternity leave and childcare and workplace accommodations play a big role. Next slide, please. And then there are the cultural changes as well. So we, particularly in the 1950s, sort of entered a phase where science and sort of the, I guess, the cleanliness associated with science became next to godliness, and the idea that anything that came from the body would be dirty and not as good as what you could make in a laboratory. And absolutely, you know, this forces of marketing were used to really underscore these cultural assumptions so that people would feel that giving formula was actually the better choice for their children. And I know my grandmother, this was something she spoke about. She was an immigrant. And now that they were in America, where things were brighter and newer and more technologically advanced, she felt that she should be bottle feeding because that's what American women did. There's also something that I notice, you know, when speaking to my patients about their decisions to breastfeed or not to breastfeed, but we have in the US in particular a very sexualized attitude towards breasts. And so a lot of women don't feel comfortable with the idea of breastfeeding because it seems somehow sexual, or that they may be risking exposure in a public place and they would be uncomfortable with that. And again, I think those are, you know, very strong cultural forces that we have to, you know, as an OBGYN during the prenatal period, we need to be able to address and discuss with our patients. Next slide, please. So, you know, I guess when you're coming up in medical school, you kind of feel that as opposed to history, you feel like your science is somehow cleaner from bias than these other areas of knowledge. But that is clearly not the case. And when I started looking into it, and I kicked myself for not thinking about it, but if you look at the journals that we read, which articles get put in the journals, what gets studied, it always comes down to who's paying for it. And for a large part of, you know, the last century, the answer to that was companies that made formula. And one of the really egregious things I had no idea was that when most of our large hospitals were being built in the 1950s, the architectural designs were actually donated to the hospitals by formula companies. So it was not an accident. It wasn't that we just didn't know that moms and babies needed to be together to make breastfeeding successful. Formula companies donated architectural designs where the nursery was far away from where the postpartum mothers were. And so this separation, which was good for formula companies, became embedded on a level that nobody even thinks to question in the layouts of our hospitals. So they also infiltrated in our medical education as far as sponsoring conferences and research studies, and, you know, which studies get done a lot of time has to do with which studies are being paid for, and which studies get published in the journals had to do with who was advertising in those journals. So there's a reason that our medical education did not prepare us to support women with breastfeeding. Next slide, please. So again, you know, the way that we talk about breastfeeding and the ways that we were taught to look at infant nutrition and how the feeding is going in the early postpartum period, all of that language gets sort of caught up in it. The basis is formula feeding as a norm. So if you look at the way our charting is set up and you look at the questions that we ask and what we chart, you know, it has to do with feeding schedules and this idea of feeding every 2 hours, which is not actually the way that breastfeeding works. But if you as a nurse have to chart on the feeding every 2 hours, then you go to the mother and you ask her, you know, and then you remind her to feed every 2 hours. And that's getting away from what is the norm, which is feeding on demand. And so our language where we talk about formula just to be safe and pump and dump. These are phrases that, you hear all the time in the healthcare setting, but are actually quite problematic. And just an anecdote that I heard on rounds this morning was we had a baby readmitted to our NICU, and it was a mother who had gone to an outside hospital for another problem, and she'd had a CT scan, and she was told to pump and dump for 24 hours. But whoever told her that, one, didn't actually look up on the safety of breastfeeding after a CT scan, because it's not necessary to pump and dump. And two, did not go further with the mother and talk about how she was going to feed her child. And so what she did was she fed her the colostrum that she had stored, and that was all she had. So what we have now is a very dehydrated and hungry baby in the NICU because this mother was given poor advice after a CT scan. And, so it goes beyond just interrupting breastfeeding as far as our safety for our babies. And, the biggest problem I think with all of this comes down to we work in a for-profit healthcare system, and from an OB-GYN standpoint, you don't get any kind of reimbursement for time that's spent for lactation education, support, treatments, anything in that first 6 weeks. It's all in the global. And so I don't want any OB-GYNs who may be here for us with this training today to think, well, that's all well and good. They just don't understand what it's like to be out there. I understand that is a problem. And I think that is something that we really need to advocate for, is that these services need to be valued so that it's affordable to have lactation consultants in your office, and that it's affordable to do breastfeeding care, or that women could get reimbursed visit with lactation consultants who are not in your office, and community peer counselors and CLCs and IBCLCs. Because the fact that we as a society don't think that this is worth paying for really is what comes down to the problem in our system. Next slide, please. So you would think when you're not getting paid for any of this, and what it is a lot of time trying to dismantle economic and cultural conditions that are working against you, why are we even bothering? And the answer is that breastfeeding is kind of just a miracle change maker when it comes to infant health, women's health, community health. So really, if you get one dyad successfully breastfeeding, you have made generational and community changes in the quality of health. And even in medicine, where that's what we're trying to do every day, I think it's pretty rare that something so small can make such a big difference. Next slide, please. So we've tried to change our language. Instead of talking about the benefits of breastfeeding and how we can improve outcomes based on breastfeeding, as thinking, well, if breastfeeding is the norm, what are the risks that we are running by going away from that norm? So as an OB-GYN, obviously we take care of women beyond pregnancy and postpartum, but lactation and a woman's decision to breastfeed or not to breastfeed, and then her success in reaching those goals, affects her lifetime health. So obesity and metabolic syndrome, for women who formula feed, they have a 10 to 20% increase in risk, 1.3 times increased risk for heart disease, 2.4% increase in premenopausal breast cancers, somewhere about 1.5% increased risk for ovarian cancer, 1.7 times increased risk for diabetes, and osteoporosis also has a dose-response relationship where breastfeeding protects for hip fracture incidence. And the longer and the more children, the more cumulative years that you breastfeed, the less risk you run of a hip fracture during your postmenopausal years. There's also studies looking into formula feeding as a risk factor for depression and anxiety, particularly postpartum, but also chronic. And the graphs that I've included here, I'm sorry, they're not well labeled, but we looked at breastfeeding initiation and exclusive breastfeeding rates going from 1965 up to 1997. And breast cancer incidence and mortality over that same time period. And I think it's just so interesting because the graphs really, you could superimpose them on each other and they're mirror images. So as you see with these cultural changes in the 50s and when breastfeeding really goes down and hits that nadir, then you see just, in that 5 to 15 years later, the peak in the breast cancer incidence. And I just think it's very telling when you look at a graph like that, how important these decisions are. Next slide, please. So the choice to formula feed increases the risk for infants and children. And I'm not going to get too much into this because I know Dr. Saley is going to talk about this from a pediatrician standpoint. And I'm really talking about the OB side of it. But infections and ear infections and diarrhea and necrotizing enterocolitis and overall infant mortality, again, breastfeeding is the most obvious way to make the biggest dent in all these kinds of morbidities and mortalities. Next slide, please. So beyond the infant mortality and the neonatal years, then the formula feeding increases the risk for children as they get older too. So again, some of the same stuff that we see with women where children who had been breastfed are less likely to be obese or have diabetes or asthma. I think it's fascinating with the breast cancer risk, but baby girls who are breastfed have a 25% risk reduction in breast cancer over their lifetime. So again, that's where it just shows some very obvious effects that you're having multiple generations. The childhood cancer risk also goes up with formula feeding. So, all of these are issues that we care about. And there's something just a few steps, as far as lifestyle choices, just a few steps before these kinds of diseases are coming up that we could be doing to really, really take a big bite out of it. Next slide, please. So money is always, I feel like, what it comes down to in our healthcare system. And again, we tend to be so short-sighted, I think, when we look at what costs money and which treatments can help and what's the most cost-effective. But this study was done a few years ago, and I guess it's been more than a few years now, time has come, 13 years ago. But they projected that if 90% of US families could comply with a recommendation to exclusively breastfeed for 6 months, which honestly is pretty not that long when you compare to what other wealthy countries are encouraging and able to do with more social support. But even just for the 6 months, that the amount of money that would be saved to the system just in the incidence of these illnesses of childhood is pushing about $13 billion. So it's a smart money choice as well. Next slide, please. So there were several other studies that went into this. I thought it was interesting, Kaiser, because they do their own insurance, but they looked as a company to look, and they, as far as they were one of the earlier systems that really started putting baby-friendly initiatives in and have done a good job trying to push that evidence. And they said they had averaged the cost of treating a formula-fed infant in the first year of life is about $1,400 more per infant. So again, the other numbers, it was 13 billion. If 90% of American families breastfed for 6 months, with 80%, it drops to 10.5 billion. So still pretty significant. Next slide, please. So this is, again, just some other studies where they were looking to try to put a number on these costs because I think there is this knee-jerk feeling that formula feeding is easier and it's less expensive because moms can go back to work, and it's not, what you lose as far as taking somebody out of the workplace and having them feed their infant for a year is too much for our economy to handle. But then when you look at these numbers, you see that that's really not true. Approximately, it takes 150 cans of artificial milk in the first 6 months of feeding, and on average, that's $20 to $25 for a can, so we're talking $3,000 there. WIC spends $600 million on formula per year. So again, when you look at choices and you say, well, WIC, spending this much money on formula, but we don't have the money to invest in peer counselors. But again, that is truly an investment that over time could save the system money. And there have been studies even that looks at the time from work that parents miss because their babies who have gotten formula are more sick. And, that also adds up. So, and then there's the environmental, the packaging and everything that goes into the bottles and the formula is clearly not good for the environment. Okay, next slide, please. So, from the OB-GYN standpoint, what is it that we can do? And again, I think we kind of have the easy end of it because really we're mostly just the cheerleader. I feel that the difficult stuff falls on the pediatricians, but there are some very easy things we can do that are not taking a lot of time, that we're not reimbursed for, that I think, right away anyone could do in their office practice. And some of that is just changing language. So I think adjusting phrases and questions. So the way it always is on the paperwork you fill out, always the way the question is, are you doing breast or bottle feeding, breast or bottle feeding? And I think that putting those together in that form really perpetuates a false equivalency, as if either or, it doesn't matter. And so changing that question to something more open-ended, like, have you thought about breastfeeding, to allow the patient to discuss, and sometimes then you sort of push for, well, why or why not, or what is it that concerns you, to find out, is it because, yes, they really want to breastfeed, but they've been told that they won't be able to go back to work if they do, or yes, they really want to breastfeed, but their mom told them they didn't make enough milk, and so they're concerned they won't make enough milk, or that's really a much better way, where if you ask breast or bottle, you're not going to be able to have that discussion. The other thing that I noticed, particularly with myself, is some of the statistics that we learned in school was affecting my counseling. So I think that schools are doing a lot better now as far as talking about implicit bias, and hopefully people would be more aware. But one of the, when I think about what I learned about breastfeeding in school, mostly what I learned were statistics of who breastfed and who didn't breastfeed. And I wasn't taught not to approach breastfeeding with people who traditionally we consider not to breastfeed. But when you know those stats and that's the only information you have, then maybe when you walk in the room, you don't ask the right question. Maybe you make an assumption. And particularly, with my Black patients, when I had my awakening after I struggled so much feeding my child, and I thought, before I went in the room, I would remind myself that I was going to talk to them about breastfeeding. And I noticed that I was absolutely more likely to broach that subject with women who looked like me, who were maybe married to other physicians in the community, who had college education, who matched all the statistics of who we had learned are more likely to breastfeed. But once I stepped back from that and made sure I asked the same questions to everyone, what I realized is everyone almost wants to breastfeed, and a lot of people just weren't being asked or supported. In the offices, sometimes we give out swag without even knowing it. I know this happens in my office. If reps come by and give things to the front desk, or they give something to your medical assistant and they put it in your OB bag, and maybe you don't even know what kind of messaging is going. So I think being intentional and making sure that you're not putting anything in your bags that is encouraging formula feeding as the norm. And what we did in mine was, there's a lot of stuff online that you can just print out. So I have handouts of breastfeeding resources, places where women can go online to get information or support. And then I also just put, a little sheet of like fun facts, which like the one about the breastfeeding, if a little girl is breastfed, things that we don't know, because I think everybody knows breastfeeding is better as far as it's healthier, but some of it is just mind blowing, and they might not know that breastfeeding affects rheumatoid arthritis or childhood cancers and things like that. So I liked having that in the bag as well. Office decor. So I think that, it doesn't cost a lot, and it certainly doesn't take a lot of time to have breastfeeding pictures up on your walls. And if you make an effort to be inclusive with those pictures, all the better. What we really had the best success as far as preparing our patients for breastfeeding was when we implemented group prenatal care. And I know that that is something that does take a lot of work. I do think, I think it's worth it. And I think that in the long run, it doesn't necessarily cost more money. I think it can be very cost effective, because with group prenatal care, the way it's set up is families that are due in the same month are in a group, and you have 2-hour visits rather than the 5-minute visit that you have with, all 50 of those families, over the course of a few days. And it's really mother-led. So there's, somebody who has 4 children, someone who's a first-time mom, and in the group discussions, they can share experiences and they can address biases. That just happens organically with the discussion. And from a physician standpoint, I'll say that if you put that in the 2 hours, then you have more time to see, GYN visits or do surgeries or the other things that do bring in revenue to your practice. And so I think it is worth the investment. But certainly that is a way that you can get really great breastfeeding education and support and address issues that you would not have time to do in just your normal traditional prenatal appointment. Next slide, please. And then on labor and delivery, they're just, I feel that we get the easiest of the steps. So the skin to skin is something that I had never seen when I was in school or in training. It was not something that I knew to ask for, but it is such a game changer. And seeing it now that we do, skin to skin universally for all of our patients, that first feed it just happens. Like we were meant to do it. And it's so much easier. There's none of this struggling to get the latch. And that doesn't necessarily carry over into the next few days, but certainly that first feed. So then when you get that skin to skin and you get that first feed, then the sugars and the temperature and the respirations are all more stable. And that leads to, you're in a better situation to work with baby and mom on the latch and really support breastfeeding rather than having to supplement so early on. So the way to do skin to skin, you don't make a stop by the warmer. Baby comes out and goes directly on mom. And everything can happen skin to skin. So it just takes a little bit of an adjustment, but drying, assigning APGAR scores, we're so obsessed with getting the weights and measurements. And I think part of that is because we have to chart it. And so the nurses need to get that charted so they can move on to their next task. But really stepping back and realizing that weighing and measuring does not need to happen until skin to skin has been completed and we've gotten that first feed. Same with vitamin K and erythromycin ointment. All of this can be done on the chest. We're not used to doing it on mom, but it's really easy to make those changes. It's just in healthcare, we're not so flexible. So, but I feel like once you get used to it and everybody, just makes new routines, it's not any problem at all. Delaying the bath is another thing that has been a very easy change that's been shown to really encourage breastfeeding, and particularly in the first 24 to 48 hours. So a lot of moms on their birth plans will ask to delay the bath. We, at our institution, we routinely wait at least 24 hours before we do a bath. And that helps because those smells from the amniotic fluid on mom's chest, on baby, whatever the chemoreceptors are and everything that's going on, it helps with the latch and it helps with breastfeeding. And that's a very easy change that we can do. Next slide, please. So, again, with our postpartum care. So on postpartum rounds, there's always, I feel like almost always there's some anxiety about feeding the baby often enough because we are just used to schedules. And again, a lot of that has to do with just reassurance that, with feeding on demand and talking about hunger cues, and then just changing the language. And so you're not saying, how much did the baby take? Instead, you're saying, how many times did the baby feed? How many wet diapers or dirty diapers, rather than how many cc's are in. And I know some of electronic medical records are set up, again, it's set up with formula as the norm. And that's a problem, and that's something we need to address, because we can know how well baby is doing based on what's going out. We don't have to measure what's going in. Next slide, please. And then this is with that pump and dump. I think, again, because formula has become our norm, we see it as the safe and easy way out. And it just makes me crazy when people don't look it up, like the one with this woman with the CT scan. We should not say, oh, I don't know the answer to that question, just pump and dump for 24 hours. Because that really, really interrupts breastfeeding and is not good for mom and is not good for baby. And there are very few things where you need to pump and dump. So really, if it's not radioactive or chemotherapy, it's going to be okay. And there are places, with the CT scans, that's in the ACR manual, and it's very easy to access. On a later slide, I've got others, but Dr. Hale and the ToxNet on, I always just Google LactMed because I can't remember the address, but whenever I Google LactMed, it comes up, and it's very easy to just double check with most of these medicines. But what you'll find is they're safe. So if you're treating someone for a UTI in a urgent care, you don't need to tell them to pump and dump. You can treat the UTI and still support breastfeeding. And then again, because we have, until we can make changes within the system that makes it so we can do a better job supporting lactation in our own office, it's just important to identify those community resources and make sure that moms have access and knowledge of them. So there's a lot of online groups on Facebook, La Leche League, depending on how active it is in your community. A lot of times they will make house visits, maybe not right now during a pandemic. There have been, a lot more trainings where we have CLCs and peer counselors. So these are people in the community that we could connect with and put our patients in connection with if we don't have the time or the knowledge to really address their concerns with lactation. Next slide, please. And so this was just a list that I wanted to make sure everybody had, as far as some places where you could look up safety of radiological exams and medications, and then places where moms could go or where we can go to get, I love Dr. Jack Newman's site. He has videos as well that help with addressing a lot of issues, common issues that come up in the first few weeks of breastfeeding. I think that's it. Thank you.
Okay. I am Dr. Elizabeth Saley, and I also work at Simon Williamson Clinic. Can everybody see my screen? Yes? Okay. Great. So I am a general pediatrician. I want to stress that I'm not an academic person. I practice general pediatrics in a multi-specialty group. I have, in the last 5 years, also become certified as a lactation counselor. And I'm not able to advance here. Let's try this again. Can you see that? Okay. I also came to my interest in breastfeeding from personal experience. This was the birth of my first child, and hopefully by now y'all know what's wrong with this picture. She's being assessed and getting all her stuff done on a warming table. I'm nowhere in the picture. She subsequently had a bath and got weighed and met my entire extended family, and eventually came to me for breastfeeding 2 hours later, exhausted. Needless to say, we did not have a good experience, and I struggled throughout her early life with supply issues. Fortunately, I come from a family of breastfeeding women, and I had sisters and a mother who helped me, and also a lactation consultant from Children's Hospital, where I had just finished my residency, who took pity on me and came to my house for home visits to help me. But I fell way short of meeting my goals with her, and so took an interest in being a better support to the women that I took care of, women and babies that I took care of. Dr. Cooper's already covered the 10 steps to successful breastfeeding, which make up the basis of the Baby-Friendly Hospital initiative. Our institution became a baby-friendly institution about 4 years ago, and it really has been a game changer. And I will say the other thing that has really changed our statistics, I feel like, is the pediatricians and the obstetricians working together towards that common goal. So as a pediatrician, when you walk in the room after the delivery, that horse has left the barn. So if the mom has not been educated prenatally, it's very difficult to change their feeding plan or to impact that at that point. So that prenatal education is really important. I wanted to quickly go through a couple of the inpatient ideas before we move on to the outpatient support. This slide comes from a 2008 study in pediatrics, and it looked at a group of women whose prenatal feeding plan was to breastfeed exclusively for a minimum of 2 months. And along the x-axis, you see the number of baby-friendly practices, skin-to-skin, feeding on demand, all of those things that they were exposed to. And the y-axis is the percentage of these mothers who stopped breastfeeding before 6 weeks of age. And you can see there's a direct correlation with how many of those practices they're exposed to and their success at meeting their breastfeeding goals. It turns out when you dig down in that data that some of those practices are more important than others, and I've got those listed here. The breastfeeding initiation within an hour of birth is by far the most important. Exclusive breastfeeding, breastfeeding on demand, and leaving pacifiers off of parts that you're taking into those babies is also really important. So important is that early initiation of breastfeeding. This comes from another study that looked at babies who had a successful breastfeeding within 2 hours of birth. And what they found was that those mothers made 54% more milk on day 4. And so that early feeding is really important. If for whatever reason that is not possible, then it's really important to have those moms hand express colostrum during that time. And I've included at the end of this presentation a video with an instructional video that you can share with moms and you yourself can look at to teach people how to hand express. Turns out hand expression works much better for colostrum, and the pumps are fine once you have mature milk that's thinner, but in those first couple of days, hand expression, even if you're pairing that with a pump, is really important. So in terms of what changes you can make in the hospital, you see here a cart, that we put the baby in and take to the room. So get that formula off the cart. Think about the kind of messages you're sending when you include that. You're basically saying, we think you're going to need this. And breastfeeding, especially for a first-time mother, early on, confidence is a huge part of it. So they need constant reinforcement. Yes, this is normal. It's normal for the baby to have an alert period for the first couple of hours after birth and then be really sleepy for several more hours. I'm really not concerned if they got that first feed and then they sleep for 4 hours. That's normal. Keep them skin to skin. Watch for early feeding cues. Yes, their stomach is only about 5 cc's right now. They really just only need those few drops of colostrum. So I'll let you guys, and they were a little bit short on time, so I'm going to let you read through those. I just want to make a couple of points. One, I think the most common reason that I see for people to supplement unnecessarily in the first couple of days, I think the most common thing would be concern about hypoglycemia. So I would encourage you, I've included at the end of this a link to the Academy of Breastfeeding Medicine's protocols. They're free to the public and they're really helpful. I would encourage you to review the hypoglycemia protocol and compare it to your current practices and the protocol that you have at your hospital. When I first started practice, our hospital protocol called for routine 24-hour glucose monitoring on every baby who had meconium stained fluid. And there's absolutely no evidence that that's necessary or helpful. So those things work their way in, and then, the glucose level gets close to the cutoff and people get nervous and they think the easiest thing to do is just give them a bottle of formula and then we don't have to worry about that anymore. So when you do have hypoglycemia though, think of other ways to treat it. So when we have a baby who's asymptomatic an hour after birth and their glucose is 30, our initial treatment is put them skin to skin, allow them to breastfeed, or and express a few drops of colostrum and spoon feed that to them. And 99% of the time that takes care of it and no formula is necessary. As far as hospital discharge, I've included here some information about what our expected weight loss is and what's an acceptable weight loss. Most of you are probably familiar with this. I would just say, keep in mind looking at the whole picture. If a mother received a lot of IV fluids during labor, or she had a particularly long labor, and the baby has diuresed a lot in the first day, you may have excessive weight loss. And if breastfeeding looks otherwise normal and well established, then I probably would just go with that. There's some protocols that call for using the 24-hour weight as your baseline when that's happened. But these moms need early follow-up in your office, certainly within 48 hours, because they're going to need a lot of reassurance and reinforcement in those first few days. I'm going to shift gears now to outpatient support. This photograph is a baby that I was assessing in my office last week. They had called because the baby had not had adequate stool output of the sort of parameters that I had given them. And so I was assessing the feeding, and what I found with this baby at 5 days was the weight was down 5%. The bilirubin was 12. This baby had a good latch. We did a weighted feed, which I'll talk about, and she really was doing fine. We'll go through some of those techniques to help assess. This is from a 2017 AAP statement about establishing breastfeeding-friendly pediatric office practices. I've included a reference to this at the end, and I would encourage the pediatricians or pediatric practitioners in the group to read through that. I'm not going to go through every one of these things individually, but just sort of hit some of the highlights and some of the things that you may not feel as comfortable with. What growth chart you're using is important. Some of the older growth charts were normed on primarily formula-fed babies. And so breastfed babies tend to get larger earlier and then grow slower compared to formula-fed babies. So in the old growth charts, they would look like they're gaining weight really fast and then they're failing to thrive because they would cross percentile lines down. So pay attention to which growth charts you're using. And breastfeeding problems, really treat those like any other problem you would for the patient that comes into your office. Take a history, observe a feeding, which probably most of us are not comfortable doing. So I'm going to talk a little bit about how to do that and then make a plan. So if you're going to observe a feeding, what are you looking for? So I just want to go through just the basics of what a good latch looks like, because that really forms the basis for knowing if you're going to have a successful, if the baby is going to be able to successfully transfer milk. So in order to get a good latch, you want to start with the baby tummy to tummy, straight on, facing mom, and nose to nipple. So if you don't remember anything else about this part of the presentation, remember tummy to tummy, nose to nipple. So, and this graphic is showing a good latch. So what you see here is a baby with a wide open mouth. This angle is about 140 degrees. You see upper and lower lips flanged out in close contact or sealed around the nipple. It's asymmetric. You see more of the areola in the lower part of the mouth than the upper part. You see a nice rounded cheek here. And you see the chin and the nose both in close contact with breast tissue. When the baby, after some fast sucks initially, you should have about a 2-to-1 or 1-to-1 ratio of suck to swallow. Moms always want to put a baby in a cradle position, and that just honestly doesn't work very well for helping them get a good latch. If they're cradling the baby, most of the time the baby's stomach is pointed up to the ceiling, and then the baby is having to turn their head 90 degrees to latch on. You're not going to get a good latch that way. So I'm showing you here a couple of the most common positions that you can get a better position. So this is a cross cradle hold. Notice the mom's hand is around the shoulders and the head is unobstructed. She's supporting her breast with the hand on the same side. Oops. And this is a football hold. Baby's legs is kind of almost in a sitting position. The baby's legs are back behind the mom's arm and she's bringing the head up. Again, notice her hand is around the shoulders and not obstructing the baby's head. Why is that important? Okay, so we're going to start tummy to tummy. You see the baby facing straight onto the nipple, nose to nipple. The nipple around the nose or touching the philtrum will elicit what's called a gape response. When that happens, the baby's head extends backwards. Baby gets a wide open mouth, and then they get that nice asymmetric latch. So you see more of the areola in the lower part, again, chin in contact with breast tissue. The nose is close to the breast tissue. They have a big mouthful of breast when they get in that position. Most of the time we counsel our mothers to grasp their breast with this kind of C shape in their hand. It gives the baby a good target to latch onto. And then the mom can also do breast compressions once the baby starts to slow down, and that helps with the milk flow. Notice the baby's hand here. Everybody always wants to restrain the baby's hand, but they have an instinct to use their hands for wayfinding and to stimulate the milk flow. So their hands should be hugging the breast. So again, if you don't remember anything else, tummy to tummy, nose to nipple, and moms can remember that, you can solve a lot of breastfeeding problems. Not all of them, but you can solve a lot of breastfeeding problems just by helping the moms with those two things. I talked about doing a weighted feed. Moms always worry that one of the most common reasons they stop breastfeeding is they think their baby is not getting enough milk. So you can use this to assess a baby that's not gaining weight well if you're concerned about it. And often I do this just to reassure the mom. Look, I know she only fed for 5 minutes, but she took X amount during that time. And so this is showing a weighted feed in my office. This is about a $300 scale. It's not a very expensive scale, but it's pretty accurate. You want to put the baby on there pre-feeding at a weight in grams, and then don't change the diaper until you do the post-feeding weight, even if they soil or wet the diaper. And you can see this little one. This was about, it was a 3 or 4 day old. So there's the pre-feeding weight and the post-feeding weight. So you see that baby took 25 cc's at the breast, which is good. And that's always reassuring to parents. Other thing I always counsel moms about is this is how you tell when your baby is full. Okay, so here you see a baby. This baby is post-feeding, relaxed, and look at his hands. His fingers are extended. So a hungry baby has a fist. And you can watch during the feeding as those hands open up and get relaxed as their tummy gets The other point that I wanted to make, I'm trying to go quickly because I know we're a little behind schedule here, that I didn't talk about in that previous slide is one of the things that Dr. Cooper touched on, is approaching every mother with the thought that they might want to breastfeed. And so this mom is a 15-year-old patient of mine who delivered in our institution about 2 weeks ago. And so she's not in a demographic in any way that you can think of that you would expect her to breastfeed. But she was fortunate enough to see Dr. Cooper and the midwives and got a lot of prenatal education. And she's giving it a whirl and came in and asked for help with the feeding. So make no assumptions. Other thing I talk to parents about a lot starting in the hospital is the size of their newborn stomach. So again, that concern about not having enough milk. So this little graphic shows you the size of the stomach as they progress from 1 day to 10 days. So in the hospital, you know, when they're saying, I don't think I have any milk, and I call colostrum when I'm talking to parents, I call it newborn milk. You already have newborn milk. Your body's been making that since midway through the pregnancy. Baby's stomach is only about the size of a marble right now, so it's just a few drops. Also, their suck and swallow is not well coordinated. So nature has made this nice, thick, sticky liquid so that they don't get choked when they eat. And so, and those kinds of reassurances as you're seeing the baby and the mom, and you can kind of do it all during your exam. It doesn't take a lot of extra time, but it's very reassuring to parents. I talked about in a previous slide, if you do have to supplement for whatever reason, try to use something besides a bottle and an artificial nipple, because that really helps mom continue breastfeeding. We use cup feeding a lot. And so this was a patient in my office who was not growing well and having some difficulty at the breast. So what I had the mom do, we did a weighted feed. And then after the feeding, I had mom hand express what she had left in her breast. And we put it in a little medicine cup, and I showed her how to cup feed it to her baby. So this is what you do with this is you just put what you have in there. You can use formula with this too. If you're having to supplement with formula, you put the cup on the baby's lower lip, tilt it just slightly so that the milk comes just to the edge of the cup, and baby's tongue will come out over the top of the cup, and they'll lap it up. And that is the most similar to breastfeeding. It's not to cause them to have a preference for something besides the breast. Incorporating breastfeeding questions and reassurance and discussion into all of your anticipatory guidance. Again, I'm not going to go through everything on the slide. I'll just leave it here for you to refer back to, because I know we're running short on time. But constantly reassuring mom at those visits. As the baby gets older and she doesn't have as full a feeling in her breast, often again, they're worried about, I'm not sure that I still have enough milk. So you want to review the growth charts and show them that the baby is growing well. And then supporting mom when they're ready to go back to work. This is a complicated slide, but I usually boil it down to what I call the rule of threes with milk storage. So I tell moms pumped breast milk is good at room temperature for 3 hours. It's good in the refrigerator for 3 days. It's good in the freezer for 3 months. And those are conservative estimates. And also talking to them about what their rights are with regard to returning to work and having pumping breaks. This was specifically addressed in the 2010 ACA, and any employer greater than 50 employees is required to give mom reasonable pumping breaks in a private place other than a bathroom. And I have written, letters for moms to take to their employers, if they're too afraid to ask for these things. I always point out in those letters what the benefits are for the employer, that we're going to have a mom who's at work more because the baby is not going to be sick and they're not going to be off of work for that. And then there is a provision also to provide insurance coverage for breast pumps. Dr. Cooper already touched on this. This is the actual website for LactMed. Look it up when moms come to you quite often with questions about, can I breastfeed while I'm taking this medication? Several years ago, we trained a group of people. We hosted a CLC training at our hospital. CLC stands for Certified Lactation Counselor. That is a 40-hour training, and it's not the same as an IBCLC, somebody that has much more training in breastfeeding medicine. But you see here the group that we trained. It was a group of labor and delivery nurses, community advocates, folks from our hospital, from our offices, our staff in our offices, the doctors. And it's just great to have somebody around that can do these kind of assessments and support other than you. The silver lining of the pandemic is that this training has gone online. So you can actually have somebody in your staff trained online. And I've included the website at the end of this for the organization that provides CLC training. And then finally, putting up, signs around your office. This is a sign that's in our waiting room. Just those kind of nonverbal things that show that you are supportive of breastfeeding. This is our staff pick it upon themselves to make some little signs that go up around the office. So it doesn't have to be anything fancy, but you're sending the message. And then community support groups can be very helpful. Marie will remember this. She came to this grand opening. This was a support group that we started in the neighborhood where we practice with the support of a local church. He provided the space for us, and it's a great thing. Again, these have been affected by the pandemic, and some of them have gone virtual, but especially for first-time moms, those outside support groups can be really helpful at continuing to breastfeed. This is a little handbook that I would recommend for anybody who's interested. I call it the Harriet Lane of breastfeeding. The pediatricians in the group know what I'm talking about. You can look up any problem that the mother-baby pair is having, and it'll give you lots of good information to help them manage breastfeeding problems. And then finally, I've got a list of resources for you and online videos back and here. Thank you.
Good afternoon, everyone. Let me see, I'm just trying to, I don't want to see me. So my name is Kimmery Bug, and I just want to say I am honored to be included in this presentation. I do not actually live in the state of Alabama. However, I should be honorary. I received my master's in public health from UAB, and also my doctor of nursing practice from Troy University. So I feel like I belong. Lots of my closest friends and family, as I call them, including Dr. Cooper and Dr. Johansson, are both there. I worked in the state of Alabama also with Best Fed Beginnings, working on baby-friendly hospital initiatives. So I actually worked with many of the hospitals that have been designated baby-friendly, and I am extremely excited about that. Wanted to talk about the community, and I won't keep you long. I can speak fast. I am Southern now. So our organization, ROSE, Reaching Our Sisters Everywhere, was developed to address breastfeeding disparities in the African American community. And we work as a catalyst that provides resources and networking opportunities for individuals and communities. So 84% of women in the United States initiate breastfeeding. For the first time the end of 2018, the country nationally met the Healthy People 2020 goals of at least 81.3% initiating breastfeeding. That was huge. That was really huge. So now approximately 84% of women in this country initiate breastfeeding. And we are extremely excited about that, and want to make sure that we know that more than most do breastfeed. The problem is there are differences, of course, in ethnicities, especially in the African American community. However, 73, it says, 0.7% plus or minus 3.5. So I go on and claim all of that and say that about 77% of African American women initiate breastfeeding. We are extremely happy about that, but that the gap is still, with all of those benefits and what we like to say, the importance of breastfeeding, it is imperative that we close those gaps. So you all are probably familiar, I'm sure, with the social determinants of health. But I'd like to say that the majority of the challenges and the barriers come from what we call political determinants of health. So the Surgeon General's call to action, which was put out by Dr. Regina Benjamin, who is another Alabama native, which followed the blueprint for breastfeeding, which was, again, put out by my mentor and the 16th Surgeon General of the United States, Dr. David Satcher, who, again, is from Anniston, Alabama. Y'all see how I build those relationships and put all that in there? But the Surgeon General, the disparities in breastfeeding in the Surgeon General's call to action outline these areas: maternal care practices, professional education, workplace, child care, access to professional support, education and information, social marketing, and peer support, and addressing infant formula. All of those things contribute to breastfeeding disparities and inequities. We've already talked about why breastfeeding is important, and that's what we do in the communities that we serve. We talk about the fact that it's not just a good thing to do. It's not just beneficial. Breastfeeding is actually important. It saves lives. And, in the indigenous community, the Native American community, they reference breast milk, breastfeeding as first food. Just think about that. Let it sit in. First food, human milk. So what we have learned is that there are particular barriers that continue to come up when we talk about breastfeeding in community settings. Those include many, but the ones that we hear a lot about is perception of low milk supply and breastfeeding in public. Those are the things that we hear a lot. So what we like to do is to talk about the major reason why there are problems with milk supply in the community, which has to do with supplementation a lot of times. So this little visual here sort of explains that if a mother exclusively breastfeeds, the milk looks, oops, let me go back one. The milk looks like this first one, the rice. If she starts to supplement, then the milk does start to slow down. If she supplements again because she thinks she's not making much milk, then she makes even less milk. And because she feels like she's making less milk, she supplements more, and truly the milk supply does dwindle. So it's important for us to help moms to understand that it's about supply and demand. It's about milk isn't stored in the breast, that as the baby suckles, the mother makes milk. And we are talking about the normal mother-baby birth-parent couplet. There are always exceptions to the rule, but we're talking about the normal mom and baby. And also breastfeeding in public. And as we all know, that there are laws in every state that talk about the fact that it is not illegal to breastfeed in public. The other concern always is that after we have discussed with moms that this is just a wonderful, marvelous thing that you should do, it is also imperative that we allow them or work with them to develop the skills to be successful at being able to breastfeed. You know, we say that it's natural, and the problem is that many of us in our communities had lost the skills because we had stopped breastfeeding for so long, and mother has to learn how to give the breast to the baby, and the baby has to learn how to take it. So we do need to teach moms how to breastfeed, and also work with the babies to assure that they are breastfeeding well. So I want to just talk about some of the barriers right now. One of the huge concerns and barriers, of course, is COVID-19. That kind of really threw birthing in general, but definitely breastfeeding in a tizzy, because people were becoming positive with COVID. The first sort of response was to protect the babies and separate mothers and babies. So all over the country, when babies were born, just like in the old days when, you know, they took the babies away from moms for 24 hours or so, it started happening again, especially to families of color. Women of color, Black, Indigenous, and people of color their babies were taken away from them at a disproportionate rate. So WHO and CDC finally did put out some decent guidelines, and WHO's guidelines here talked about the fact that they did literature reviews and actually worked with parents who were positive, about 48 mother-baby couplets, and about 3 of the mother-baby couplets, the baby became positive, but they continued to breastfeed and the babies did fine. Again, it was imperative that at the time that they make sure that the moms did wear masks and wash their hands, and then not really cuddle and spend a lot of times while they were going through the COVID process and being positive. And also, again, the CDC came out with some decent guidelines more recently also. And these are some really good key points. Continue to breastfeed, make sure that the moms wear the mask, that they wash their hands often, and then they can continue to breastfeed. So Dr. Melissa Bartik, who is a researcher and a good friend of lactation support providers throughout the country, said that out of an abundance of caution, all infants, regardless of mom's COVID status, should be breastfed from birth, and breastfeeding should be promoted and supported during the pandemic as a public health strategy to maximize infant welfare. So we want to talk a bit about the uprisings, because we're talking about barriers. What we need to know, of course, is that racism makes us sick. Dr. Cooper mentioned how when she was trained as an OB-GYN, the research and the literature said, again, that Black women don't breastfeed. As I traveled throughout the country, working with hospitals on the baby-friendly path, many healthcare providers would say that same thing to me. Again, I want to reiterate that Black women definitely do breastfeed, 77%. That is more than most. And so we need to definitely adhere to that. And what we find is that our mothers in the community are what we call resource deprived. They have not had the opportunity to learn much about breastfeeding. And you don't know what you don't know. You know what you know a little bit about what you don't know, and you don't know what you don't know. Johari's window. And many, as physicians, told me, well, we only have 6-7 minutes with the mom. So we talk to them about hypertension and heart disease and gestational diabetes, because the literature tells us that Black women don't breastfeed. So that is definitely just not true. Oh, forgive me. It had just started really pouring down here in Decatur, Georgia. So again, the stress that women have, and especially a lot of moms being essential workers through this pandemic, has been extremely difficult. This little picture here is at Grady Hospital. This was white coats for Black Lives. And these are the physicians from Morehouse and Emory and Mercer and also Wellstar that all came together to at least give reverence to the fact that disparities, inequities do exist. And there are things, especially in healthcare, that we need to do to address it. A wonderful article again about sudden infant death syndrome and as a social justice issue. This is Dr. Cecilia Torme and Melissa talks a lot about sudden infant death syndrome, SUIDS, and how it is addressed here in this country and in developing countries all over the world, which is very different, and as a great article also for you to be able to see. Emergency preparedness, like what we're going through now, all of this stuff, moms can continue to breastfeed. Again, very often, as Dr. Beth mentioned also, that we have a knee-jerk reaction when things come up and we just say, oh, there's this little safe substitute, so just do this right now, because we don't know how to manage lactation through problems and concerns and issues. So what we want to say when we are going through these hurricanes and tornadoes and the burning in California, my youngest child is home now. He was at UC Berkeley and, with asthma and couldn't stand the fire, so he had to come home. But we need to make sure that they head to safety. They keep offering the breast. They learn how to hand express. That is vitally important. And one of the prenatal things that in Baby Friendly Hospital Initiative, that moms learn how to, and providers teach them how to hand express. Store extra milk if possible. Delay weaning. We have to talk about milk sharing. It's happening. It's happening a lot. Just a very dear person in our lives, reaching our sisters everywhere. The mom died recently, and she had twins, and the twins went home with dad, and the community has done a phenomenal job in providing breast milk for that baby, those two babies, and think positive. Some of the challenges that we look at when talking about breastfeeding, we like to address peers, partners, policies, and programs, as the Surgeon General's call to action also addresses. We did an African American breastfeeding blueprint. Lots of stuff came up. We interviewed researchers, healthcare providers, midwives, doulas, lactation support providers throughout the country in all 10 public health regions. Some of the things that we found in the African American community is that every week after initiation, about 20% stop breastfeeding because of problems, barriers, challenges that could usually be helped. And so one of the things we've done is set out to develop programs to address this, these moms stopping breastfeeding. Peer-wise, there's nothing like someone that you trust in the community who is able to affirm answer some questions and help moms to continue breastfeeding if there is a problem. We need lactation support providers at every level. The peer, the friend, WIC breastfeeding peer counselors have changed the landscape of breastfeeding in this country. We need the CLCs, the CLEs and IBCLCs, and there are also breastfeeding medicine physicians. All are needed, and peers in the community are what is truly, truly making a difference. Partners, we even throughout, especially the southeastern states, as I traveled working with the Baby Friendly Hospital Initiative, Breastfed Beginnings, and also with Empower, we used to hear that dads just felt invisible. Talked to one dad that said that in the waiting room, he said he'd been there for 2 hours and I was the first person that addressed him. It was all about mom, and that just does not work and cannot work when we are trying to sustain breastfeeding over the long run. Fathers are there for sure, and they need to be addressed. Same-sex couples, this young lady had a wife, she and her wife, the baby was 1 week old, and they were both providing milk for the baby. She pumped 10 ounces at a sitting. Again, the baby was about a week old at this point, and she came to a training that we did, and she had been pumping since her wife was about 6 months pregnant, and she was able to also breastfeed and provide breast milk for the babies. Grandmothers are a needed resource, and also they need the information. There are generations of women who were not able to breastfeed for many reasons, especially, again, Black, Indigenous, and people of color. And therefore, it is imperative that we also make sure that grandmothers get information and resources. We say that these mothers and birthing people are what we call resource deprived. Baby Friendly Hospital Initiative, I'm sure you are all very familiar with this, but I need you to look at Mississippi. Blue Cross Blue Shield mandated that all of the hospitals get on the Baby Friendly Hospital pathway, and they fought it tooth and nail about 6 years ago. We worked with them with CHAMPS and Boston Medical Center. Now over 2/3 of the hospital are baby friendly, and you can definitely tell a major difference. Their breastfeeding rates have gone up tremendously. They are no longer last, and y'all better watch out, and us here in Georgia too, because in Georgia, we always say, thank God for Mississippi, Alabama, and Louisiana, because us, Georgia, and those other three, we're always fighting for the bottom. So Mississippi is not on the bottom anymore, and we are very excited about that. Imaging, and it makes a difference. These are nursing pods in the Atlanta airport. We were the first airport to have this, and we made sure that they also put why it is important to breastfeed on ours, so that, again, we are spreading the message. We're changing the narrative, allowing parents to know that, again, it's not just a good thing to do, that all those wonderful things that Dr. Jasana Cooper talked about is very true in the literature now. Telehealth right now is what we have to do. There are all kinds of CARES Act initiatives to promote telehealth. Mothers and birthing people are having tremendous problems trying to continue to breastfeed, because generally there is so much anxiety and depression because of the pandemic, because of the uprisings, because of the floods, because of the climate change. So we need to stay in touch with the mothers and birthing people through telehealth. This is going to definitely be the wave of the future, because when done well, this can be a tremendous aid to what it is we are already doing. And then images matter. This is a bus that is in Memphis, Tennessee. And when they ran these ads on the bus and on billboards, they saw increases in the WIC breastfeeding. I also just wanted to mention that you all have some phenomenal programs going on in Alabama, such as the doulas, there are tons of doulas that we know that we've worked with, Rose Community Transformers. There is a prison ministry where Chantel goes in and works with the moms in the prison, and you have lots of lactation support providers at every level. Use them. They are phenomenal. They know when to refer. They know how to affirm mothers, how to counsel mothers, position and attach, do all those things that are low-lying fruit so that moms can be comfortable and not tender and sore and be successful at what they choose to do. Representation to power. We know that a lot of the problems that we face or the concerns that, this is reality. Some people start at a place of privilege. Some people start in a hole. So that's what we have to realize, that, equity and equality is not present for everyone, and we have to meet folks where they are. And the most important thing is to listen to mothers, listen to birthing people. They know what's going on with them. They know when they feel bad. They know the issues and concerns they have. Again, not, do you plan to breast or bottle? What do you know about breastfeeding? What are your questions about breastfeeding? And then when they choose, or if they choose not to, then that's just absolutely fine. But we just need to make sure that it is an informed choice. What mothers have told me so often is that they did not have the information and resources to make that informed choice. And thank you.
Okay, I'm Tracy West, and I am the Infant Mortality Prevention Coordinator at the Alabama Department of Public Health. We don't have a lot of time left in our training today, so I am going to go ahead and go through this fairly quickly. This is just an introduction to the program, so we'll be contacting each physician, so we'll have time to go over this individually. Okay, just a little bit on the background of choosing the breastfeeding friendly strategy that we've chose here at the Alabama Department of Public Health. We, in December, on December 20th, 2018, Governor Kay Ivey asked the Children's Cabinet to address the issue of infant mortality in Alabama. So that was the starting point. On June 20th, 2018, the Children's Cabinet agreed with the subcommittee's recommendation to start a 3-county pilot project to reduce infant mortality by 20% over the next 5 years in Montgomery County, Macon County, Russell County. And more than 650 preterm births and 45 infant deaths occurred in these 3 counties in 2016. So we needed to look at reducing the infant mortality rate. Funds were allocated to several state agencies to carry out the project. Because of time, I'm not going to go through all of those, but we, with the Alabama Department of Early Childhood Education, Public Health, Mental Health, as well as Alabama Department of DHR. So we're all working together to reduce the infant mortality rate. Okay, in choosing this, the breastfeeding strategy, we worked on researching options that we could use to help increase breastfeeding, since breastfeeding does help reduce infant mortality. So I looked at several states and I came across in California that they were basing a program on the research that was done through the American Academy of Pediatrics, which was the Breastfeeding Friendly Pediatric Office Practice Article and Guidelines. So I reviewed over that and determined that working with providers, obstetricians, pediatricians, and family physicians for a breastfeeding-friendly certification process would promote breastfeeding most effectively, because patients are seen through their pregnancy and during the pediatric visits once the baby is born. And then we introduced that to our breastfeeding group, and we have a work group. We presented it there, as well as to other breastfeeding experts and people working in the community, and they all agreed that this would be a good place to start. Okay, so who will be participating in the baby-friendly provider program? Again, like I said, it will be obstetricians, pediatricians, and family physicians. Again, obstetricians will be able to provide early breastfeeding education and support to moms during their pregnancy. Pediatricians will be able to provide continued breastfeeding education and support for that first, to support breastfeeding for the first year of life. And then those family physicians will also be important to those women in rural areas that might not have access to pediatricians. Okay, these are the 7 steps to the certification process that we have decided. Again, it is based on the AAP's recommendations, but these are the ones that we decided to go with. Breastfeeding, number 1, breastfeeding policy for the office, 2, staff education, 3, patient education, 4, clinical services, 5, clinic environment, 6, community resources, and 7, workplace lactation accommodations. The first one was breastfeeding policy. Establish a routinely communicate to all clinic staff a written infant feeding policy that promotes, supports, and protects breastfeeding and human milk as a normative standard of infant feeding and nutrition. 2, staff education, provide initial and ongoing competency-based education and training for all clinic staff on topics necessary to establish and maintain the infant feeding policy and protocols that support delivery of comprehensive breastfeeding education and clinic services. Patient education, provide accurate and evidence-based information about breastfeeding and human milk to all pregnant women, mothers, and or caregivers that is based on current national recognized guidelines. Clinical services, provide clinical services that promote and support breastfeeding for the mother-baby dyad as the norm for infant feeding and nutrition. Clinical environment, establish, provide, and maintain breastfeeding-friendly clinic office environment. Community resources, collaborate with local agencies and health professionals to ensure continuity of care and breastfeeding support in the community. Workplace lactation accommodations, provide and maintain effective lactation accommodations for all employees within the organization. Now, I'm not going to have time to break down each of those. That was what I had planned, but for time restraints, we can't. But again, once I reach out to the providers, I'll go in detail with all of those steps. We have a guide. This is how the certification process will be implemented. Like today is the kickoff training. And then ADPH, starting October 1st, will start reaching out to the individual providers in Montgomery, Macon, and Russell counties. And then for those that participate in the certification process, they will receive a toolkit, face-to-face visit by Zoom until the COVID issue is not part of this, for quarterly education, training, and assistance through the certification process, and then at least 1 office visit after the first quarter. ADPH will be available as needed. We are partners in this process. The toolkit will include step-by-step instructions on how to become a baby-friendly provider. It will have educational materials for the provider. It will also have educational materials for the patient. We'll have a resource guide. There will also be posters in the toolkit for physicians to post in their offices to encourage breastfeeding. And then we'll also provide each office a tear-off easel display, which will include numbers to national breastfeeding hotlines so that patients can have access to that after leaving the office. What will certification mean for providers? Providers will be certified as baby friendly, which means they are encouraging mothers to breastfeed, they're supporting them, and they're helping them reach that goal of breastfeeding for at least the first year of life. We also will provide at the end of the process for notoriety and recognition. You will be posted on the Alabama Department of Public Health's website as a baby-friendly provider, as well as other breastfeeding websites. Agencies through the state have also agreed to add you as a baby-friendly provider. In summary, our main goal of this program is to introduce women to breastfeeding early in their pregnancies, and then support them through their breastfeeding journey. Physicians have a great influence over their patients, as we know, and so we just really want to get physicians talking early on in pregnancy about breastfeeding, and then having that support through the pediatricians and family physicians to keep that going. All right, we have met our time. So thank you all so much, and I guess I will turn it back over to Brandon now.
Thank you so much, Tracy. That concludes our program for today, but I want to thank Dr. Cooper, Dr. Saley, Dr. Bug, and Tracy for being here, and thank you for joining us. Please remember that you can refer back to the training and resources anytime on demand. Have a great day.